Carrie, we can go ahead and call to order. Just everyone on the call, please be advised this is being recorded, so anything said verbally or shown on the camera or chat or typed in the chat can become part of the public recording. We do need one more member for quorum, but we're going to go ahead and get started and ask for members that have joined during the announcement.
So we're going to call this meeting to order.
9:02.
And then we'll do the roll call?
Yeah. Okay. All right, roll call. Allison Welch.
Present.
Ariel Tarango. Barbara Solfa, present. Candace Williams. Carrie Lewis, present. Corey Usher.
Present. Corey's here.
Thank you. Dale Woolridge is unable to attend. Deb Burkick.
Present.
Garth Gamer.
Present.
Heather Miller.
Present.
Josh Gaither is unable to attend. Julie Augenstein. Laura Smith.
Present.
Maria Salas. Present. Michelle Guadnola.
Present.
Paul Dabrowski. You see him online, so. You see him online. Paul, if you can get off of mute, just chime in when you can. Oh, thank you.
Thank you.
Ralph, thank you. Ralph Kelly. Ray Proa. Rebecca Harrow's unable to attend. Sean Bowker. Tiffany Streever. Tom Flanagan. That might be him right there. Tom Flanagan, did you just join? Showing 11. I need 13. Came and fire. Sorry, I'm like, is that you, Tom?
Yeah, sorry about that.
Counting 12, I need 13. We can continue with an informational meeting, if you like. We just won't be voting on anything.
Okay, so we can go over the chairman's report and all of the updates, right?
Yeah, and just at each section, just advise everyone that we're in an informational meeting, we don't have quorum.
I'll just type in the chat if they're a voting member, missed roll calls, type in the chat so they're present.
Okay, that's great.
Okay, so we're going to get started. So we have the attendance report that was attached from our last meeting. If there are any questions about that or inaccuracies, let us know. We also have a new member that is online with us, Corey Usher. So welcome, Corey. Did you want to say anything? Introduce yourself to the group.
Sure. First off, I want to say thank you very much for having me be a part of this group. I'm very excited to work with everybody. I see a lot of familiar faces. Been in the industry for a while now. Haven't done everything, but I've been in hospital, pre-hospital, and fire department. And just looking to learn what this committee is about and what we're working towards, and see if I can have some valuable input into the direction that we're trying to go. So thank you for having me.
Perfect. Thank you and welcome. We do have some vacancies. There's a total of 3 of them. We have state designated level 4 trauma center program manager. Anyone interested can send their resume to Shelley. We also have law enforcement representative with active EMS involvement. Also, if you're interested or know anybody, please have their resume sent to Shelley. And then also pre-hospital EMS coordinator is an opening, and that email would go to Sarah at exec director at saemscouncil.com. Also, the upcoming meetings for 2023 are available online. If you could take a look at that and do your best to attend. And then I think next up are bureau reports. Department updates, Chief Garcia.
Good morning. It's nice to see you this morning. I am going to tag team some updates this morning with our radio personality, Adam Rodriguez, with the radio voice. Would you like to take it away?
Sure. Thank you. I hope you all can hear me. This week is National Crash Responder Week. Governor Doug Busey declared this week, November 14th through 18th, Crash Responder Safety Week in Arizona. This is acknowledging that from 2019 to 2021, there were over 100,000 traffic-related crashes involving injury or death in Arizona, and to move over and slow down when you see flashing lights. With that, the department has shared a blog this week in recognition of National Crash Responder Week, and will continue to promote free traffic incident management courses available to first responders, and information available to everyone on the AZTIM website. We can link that in the chat if anybody needs it. If you have any further questions about that, you can reach out to David Harden for additional. Funding updates. The department has identified a small amount of funding to be able to support rural paramedic education. And we want to thank the 4 regional councils for being willing to develop plans to award this funding in each region to help increase the EMS workforce. We've seen the state invest significant funding in nursing education over the last year to combat staffing shortages, and the Bureau recognizes that it will be important to work on identifying additional funds for EMS training and education to maintain the EMT workforce in Arizona. With regard to IT updates, we've been working on implementing the new EMS portal, making its way to being active in 2023. Most users are aware of our portal from bi-yearly visits for certifications, but the new portal will have lots of new features and be able to track your training and different things like that. So hopefully it'll be a little bit more useful. We're looking to go live after the first of the year with it. The new 911 dashboard, which Vasa will cover during later on in the agenda, and a blog to go out next week. We're very excited about that. Not necessarily real time, but as close to real time updates as is possible regarding significant data. And then Ann will cover NMSIS 3.5 later on in the agenda. Some rule updates, which are sent out via GovDelivery. The EMS scope of practice update based on national standards became effective on September 22nd. The updated table 5.1 is available. We can link that through our website. Air ambulance staffing rules were also updated and became effective on November 8th, 2022. This rule update was intended to allow flexibility in air ambulance mission staffing, and including nurse, and nurse paramedic response. Lastly, we're keeping our eye on pediatric surge. We've seen a significant increase in the number of RSV and flu cases. Those two, coupled with existing COVID cases, are presenting a particular challenge. So we are working closely with the Healthcare Coalition to monitor pediatric surge and bed availability statewide. We have state dashboards and additional resources. If any stakeholders have any questions, you can reach out to me for that. My name is Ed Rodriguez. And that's all I have for bureau updates.
Wonderful. I'm going to Sean Boker join, so we do have quorum. Okay. Thank you, Sean.
Dr. Augenstein says she's trying to sign on too, so hopefully.
Okay.
Next up for bureau report is new bureau staff. We have just.
We usually take care of that.
Oh,
introduction. Thank you. That's okay, Rachel.
So we are thrilled to share that we have some new staff, some that are in the room with us today. Just going around the table, in our last statutory committee meetings, we did introduce them, but we're going to introduce you again. We have Russ Lindholm, who is our new EMS regional coordinator serving the Western region with us today.
He brings with us over 30 years of EMS experience. We also have Stephen Ferris, who has joined us, and he is also an EMS regional coordinator that primarily serves the central region. Is that right, Steph? And significant EMS experience as well. We're thrilled to have both of them on board. In addition, they may be on the line with us remotely today. We have Brian Hubble, our new CON and Rates Program Manager, and Jeff Kerr, our new Compliance and Enforcement Manager. And both of them, again, also bring to the Bureau significant background and EMS experience, and we are just thrilled to be able to have them on board. Great additions to the team, and we know that stakeholders will appreciate working with them as well.
Next, I can cover the naloxone leave behind program, if we can maybe click to that on the website. So we do have links in the agenda. The Bureau was awarded another 4-year cycle for the FR Care grant. So Julia Vinton will be the lead for that grant for us. As part of the grant process this time around, we are focusing not only on law enforcement naloxone administration and distribution, but also on really expanding the leave behind program. So we anticipate developing more kind of educational materials, trainings, and resources that will be available. Right now on our website, you can download the training PowerPoint. There's also a link in how to obtain naloxone. Although as we build up with the grant, that process for ordering naloxone will change, will be done through the Bureau of EMS and Trauma System rather than the Bureau of Injury Prevention. So just I wanted to remind everyone that we do have this in place. And thank you, Shelley, also sharing. We do have a new ADHS opioid website that shares kind of current active opioid data as well. So if anyone has any questions you'd like help with starting up a program, let us know. But as we do build up the grant process in the next several months, we do anticipate there being a lot more communication coming out about that. And I'll hand it off to Ann. I believe you're on the line for the BEMSTS 3.5 update.
And I'll stop sharing my screen if you want to present.
Okay, I will try to do that. Good morning, everybody.
And I gotta move my slide.
Okay. Can you see the presentation?
Yes, we can. If you can just maybe make it bigger.
It's humongous on my screen. Let's see.
Maybe slideshow version will make the slides a little bit bigger.
Oh, it should be in the slideshow version. Okay. Well, then I'll just move it over maybe. Sorry. Is it showing up in the slideshow version? Is it bigger now?
No, it still looks the same.
Okay. All right. I'll try going to slideshow first. The problem is that it hides where the screen is that I can actually share. Okay. All right. So Shelley, do you have, because I want to make it big enough for everyone to see. And it is showing up as a slideshow presentation on my side.
Now it's the black screen.
Yeah, now it's a black screen because I'm trying to see if I can switch it over. But let me try sharing my entire screen. I don't want to hold this up. Okay. Let's see what we end up with. And if not, I'll have Shelley. I emailed her my presentation in advance, partly because I was worried about this happening. Okay, so I'm assuming you still can't see it in normal slideshow form.
Correct.
Okay, yeah, Shelley, can you pull it up? Because on my side I've got it, but I'm sure it's user error. Or I can just try to make, I guess, it bigger on here. Let's see. Let me know if this works.
What does everybody see now?
And may have to stop sharing.
Oh, Anne, can you stop sharing, please?
Yep.
Oh, technology.
Friend or foe?
There we go. I think getting it up took longer than the actual presentation because it's only like 2 slides. So first, I just want to start with a short update, and then I'll go through these. So I sent out an email yesterday to anybody who's on the EMS Registry Users Group, the EMS Agencies listserv. So basically announcing that we started accepting, or AZPR started accepting V3.5 data, which is that next version we're going to, in October successfully. And we have now completed also our onboarding process with NEMSIS, which is the National EMS Information System, to which we send some key variables, and we are successfully uploading to them. So we are officially live, which is great. We're one of the first states, not that it's a race, but it's nice to say that we can accept this data so that any agency that is interested in changing is able to do so, and we can still keep the data going to NEMSIS and our partners. There is going to be more and more resources posted on our public-facing website, and just a reminder that we will accept the current older version, if you haven't switched over, which is version 3.4, up until June 30th, 2023. So there's about 7 months left to transition. And let me just, and there's an extended presentation of this that I'm going to post on our public-facing website that has a lot more details and tables, but I had a shorter time to talk than those slides would have taken. So I just wanted to go through these. Okay, so some key changes, kind of why we're going to 3.5, why is there going to need to be a change from 3.4. So some of the questions that we ask, you all ask, are like, what kind of call was it? So there have been some improvements to type of service requested with added and updated values and labels. So it's not just, it used to be just 911, interfacility transport, medical transport. That was somewhat confusing. It wasn't always being used properly. And so the variable's still there, but they've added some values and changed some labels. And then what type and level of response, we get this one a lot. So there's been a change to the primary role of unit, which was just kind of what the unit normally could do, not necessarily what it did do. And so to answer the part of the question, there's another part later on that answers this too. That same variable has actually just been changed to unit transport and equipment capability. So essentially that answers just what is this vehicle equipped with and able to provide as far as care and the level of service that it could provide if needed. Another question is, if there was a patient, were they evaluated or treated? So there's going to be several of these in a row where we've replaced what is currently the incident/patient disposition, which if you've seen it, it has ended up with some of them being basically long sentences with several commas and lots of different things going on, and still isn't really clear sometimes what happened to the patient or the crew or who did what. So this variable has been replaced with 5 new variables with much shorter values that are pretty clear and to the point. So in this case, it's been replaced with the patient evaluation and care. So did you have patient contact or did you not? Or was it a canceled call? And it's as simple as that for that one. What did the crew do? Once again, that was recorded before in the longer variable. And there's now a new crew disposition. And same thing with transport. We had tried to stick that into the very long values of the original disposition, and now there's just a transport one that says, did you transport? Did you hop on someone else's ambulance and help transport? That sort of thing. So can you go to the next slide, please?
Yes. Ah.
Sorry, Shelley. Now it's on you. Okay. Okay, and then the last of the questions, if a patient refused care and or transport, why? Didn't really have a good place to capture this unless you poked around, and even then it wasn't really clear. There were a few values in our old disposition, so now there's a separate variable that's one of the 5 that is reasons for refusal or release. And it's a pretty good list, and obviously this one would only be something you'd fill out if it actually was a refusal or release, not, you know, a canceled call, not a transport, not a treated, and, you know, whatever. So, and then what level of care was actually provided? This one is so important, and we have really struggled with the current data set and previous data sets with capturing this. And so I'm really excited that we have a new separate variable that improves complete determination. And I think that should have been documentation, with one specific data element, which is level of care provided per protocol. So before, we kind of piece things together between one on the previous slide where it said level of service, which was actually what you could provide, not necessarily what you did do. There was a e-payment variable called CMS service level, which is problematic because, number one, the crews aren't going to know really what the service level CMS would have called it. And also that's a billing variable, which isn't really something that we're asking. And it made agencies a little bit uncomfortable, and also not all agencies bill. So this one just says basically per your medical direction / protocols, what level of care did you provide as a crew? And so that one I'm hoping will really help us answer those questions that we get quite often of BLS and ALS and critical care and things like that. And then how ill was the patient before and after EMS care? So there have been improvements made to both initial patient acuity and final patient acuity with some added values, including one that basically said that their patient was, it wasn't a treat patient case. So that makes it a lot better. Reasons for interfacility transport or medical transport. We didn't have anything like this before. You can kind of look at the primary impression, but really that's based off of the hospital's diagnoses, and it gets a little tricky. So this is actually a reason, and it's a pick list. There's a separate variable that we didn't add as a requirement. It is available. That's a text one where they can say the justification for transfer. But this one's a pick list. It's a general category of the reason why the patient's being transported, interfacility or medical transport. And super important for capturing, obviously, things like, are they transporting because of trauma, and things like that. So I'm really hoping that will add a lot to our data quality. And last one is, if transported, to what type of destination and why? So there have been improvements to the data type of destination and hospital capability. So type of destination, they've added a bunch of values. There was one that was like assisted living / nursing home, which is not granular. So now they've added assisted living, and then separately nursing home, and then separately skilled care facility, plus some additional ones like mental health care facility. And then hospital capability has been changed from, you could only select one capability before, like the reason that you're picking that hospital. And now you can select as many as might apply to the situation.
Anne, we might have a question. Anne, we might have a question. Dr. Williams, do you have a question? Okay, maybe not. Sorry, am I on the right slide?
Yes, you are. And can you go to the last slide, please?
All right. I thought maybe Candace Williams raised her hand for a question, but I'm mistaken.
Well, if anybody does have questions, I'm always available later. I do, like I said, have a more detailed presentation that I plan to post and maybe present at EMS. And I just wanted to thank everyone too for all your hard work. Congratulations to Avondale Fire, by the way, which was the first agency to go to 3.5 and successfully send data. I have to call them out because they got run over by the wheel because they were the first ones, and they helped a lot with developing some tools too. Okay. And the last slide would just say, Thank you.
Moving the slide now.
That's okay. Yeah. If anybody has any questions at all, please let me know. And thank you for your time.
And can we thank you too for helping us to stay on track with AZ peers and making sure that all of our providers are able to continue reporting through BEMSTS version 3.5. My understanding that Arizona is among the first states to be able to accept version 3.5, and that's really a testament to you, and we appreciate you being a resource to all of the EMS providers. Thank you, Ann.
Thank you very much. It's my pleasure.
All right, and next on the agenda, we have Aster update. Chris, are you on the line to share some additional information with this group? I'm not sure if we've had this on the agenda yet for TEPI.
Yes. Okay. So most of you have already seen, my presentation on the registry and the changes that are coming up, but I just wanted to give you a few new updates that I have. I don't have an answer as to which program we're going to be going with before you guys get too excited. And so in the past, we had said that ESO would be releasing their new product next year, at the beginning of next year. And I've spoken to them, and they are actually pushing that back until the end of next year. And so for right now, we're still looking at all of our options to make sure we're looking at everything we can to make sure we're making good decisions. But I wanted to let you guys know, if any of you are going to be going to TEQIP in December, I believe it's the 12th through the 14th, ESO will have a booth there. And I reached out to them, and they said that they're going to be doing demos of their new registry product, of what they have ready so far. So if any of you are at TEQIP, feel free to stop by and ask them questions and see what you can see of the new registry. ImageTrend will also be there, and they will also be doing demos of their registry product. Because I know a lot of you have had a lot of questions about what they look like, what's the functionality, and so TEQIP will be a really great place for you to ask the vendors directly and see those registry systems. So those are the only real updates I have as far as where we're going with the registry system right now. Does anyone have any questions for me?
Carissa, it's Rach. I think we also have a little bit later in this agenda an opportunity to touch on this as well if there are questions. And we also want to thank you for being such a great resource to all of our trauma centers, because you really make it, the reporting, as seamless as possible. And we look forward to working with the trauma community on what the future of the trauma registry looks like.
Yeah, absolutely. I really enjoy working with all the different facilities and getting to know their needs and stuff for the registry. So hopefully it'll be a smooth process going forward.
Wonderful. Thank you. I think next up is updates. Maria, about trauma registry user groups.
The two updates that we discussed on our last track meeting is we're going live with AIS 15 next year, January. And then we went over the changes for the NTDB dictionary, and just a few pre-existing conditions are gonna apply for, they're not gonna apply for 15 or years or younger anymore. And then one big change for us is now for open fractures, we will be able to take the dose that EMS gives before arrival to hospital. We weren't before. So that's a big change for us. It will, because now before you had to do the first antibiotic at arrival at the hospital, and they would not start it right away. So we would not get credit for that. And now EMS starts a lot of antibiotics on field. So starting next year, we'll be able to enter that into the data. So I think those were the only two big things we discussed.
That should help. Next up is Heather Miller, Trauma Program Manager Workshop.
Hi, yes. So we had our trauma program manager meeting. It was good. We're working on in-person, continuing to work on in-person and Zoom meetings, as well as, leaders to do presentations. They had breakout sessions and the ability is just kind of for the level ones to help the level fours. So overall, a great meeting. Working on finalizing the date and the location for the next meeting in the new year.
And then Raymond, EMS Registry User Group.
Yes, we met, the EMS Rug Group met on 15th. A lot of the stuff that, sounds like a lot of the stuff that I've been hearing is stuff that we covered. We're actually way ahead of it. At that time, we were talking about the 3.5 data set versioning and as far as transitioning to it with the steps and things like that. But I believe we already have a couple of fire departments and actually one I know for sure that's sitting 3.5 data. But a lot of the stuff that we talked about, I believe, is already well above that. So I think Ann covered it pretty well. So that's about all I have.
Wonderful, thank you. And since we've met quorum, we have some discussion and action items. Minutes from our last meeting in July. I think they were attached. Do we have any?
Ask for a motion to approve.
A motion to approve the minutes from July?
Motion. This is Julie.
Thank you, Julie.
Thank you, Julie.
Is there a second?
We need a second.
Allison, second.
Thank you, Allison.
Perfect. The motions are approved.
We'll ask for amendments.
It's my first time. Are there any amendments to the motion or to the minutes from July? Any changes?
Hearing none, we can move to a vote.
Hearing none, we're going to move to a vote. Do we have all those in favor say aye?
Aye.
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 All those opposed say nay. Is anyone abstaining? Perfect. It appears the ayes have it and the motions are approved as they stand. Thank you. Next up,
At possible.
is VASO to discuss. Do I need to do a motion first?
No motion needed for this one.
Okay. VASO, I believe you're up next to talk about hip fractures.
Shelley, do you want me to share my screen or you are sharing the report?
I can display it.
Okay, perfect. Thank you. So last time when we had TEPI, we had a couple of members requested doing a report on ground level hip injuries. And Sean, I think, yeah, I think I saw you when you are here, and candidates also showed some interest in the report. So here is a draft report. I'm going to present some data for the last 3 years. And what we did is this is analysis from hospital discharge database, because we wanted to get a picture of falls which are not presented at the trauma centers. So when we queried hospital discharge database for the year 2019 to 2021, and as you say, the hospitals we divided into trauma centers and non-trauma centers. And total number is, and the combined is both the frequencies together. And so in the trauma center, we had over the 3 years, total 18,000 ground level that hip injuries were reported, whereas in non-trauma centers, almost more than 200,000. So that is like a huge number of trauma hip injuries, is getting presented to our non-trauma centers, which is our registry. We missed this in our registries, and for a reason we missed, because we do not want to include, and that is understandable, but we wanted a full picture of hip injuries, and here are the numbers. Then we have almost 236,000 hip injuries over 3 years. And if you see the distributions, can we scroll down a little bit down, Shelley? I want to see the graph. Yeah. So the graph is 2009, all 3 years separate, and it just shows the distribution of between the trauma centers and non-trauma. When it says non-trauma, that is non-trauma centers presenting data to hospital discharge database, and trauma is a trauma centers. It's nothing. There is no other ICD codes difference between the two. Then we can go to table 2. The age groups were selected based on some of the literature available for the falls. What they were doing is they were using this age group. So I just decided to use this 0 to 40 years, 41 to 60 years, and 61 plus years. And as you can see in the percentage column, or right over here is that majority obviously work from 61 plus years. So 84% was in the trauma centers. Compared to non-trauma centers, it's 55%. So the non-trauma centers are seeing more of even less than 40 years old and 41 to 60 years old compared to the trauma centers. So this may suggest that yes, trauma centers at 61 plus years are more, and it is also because the severity of those patients is higher, and hence they go to trauma center. So we can go to the next table. So table 3 talks about the length of stay. Can we scroll down a little bit? I want the full picture of that table. Yeah. No.
You want 3 or 4?
Table 3.
Just all of 3. There you go.
Yeah.
Make it smaller.
Again, the length of. So the first column is like admitted, and if you see the admitted, the percentage of total cases in the trauma centers, 48% were admitted, whereas in non-trauma center, only 16% were admitted. Which again, that makes sense. Not that severity of injury is not that high. Even though the numbers are pretty high presenting into non-trauma centers, they are getting discharged from the ED and not getting admitted. But then when you, and then that's the discharge cases. And then when we look at those who were admitted and their length of stay in the trauma centers is 4.9 days is a mean, and the median is 4 days. And in the non-trauma centers, again, 5.3 or 4 days the median. So what it tells me that, okay, those who are getting admitted, there is no difference between the trauma centers or non-trauma centers length of stay. It's almost around 4 days is a median between in both of them. And those who are getting discharged, percentage of total cases, so 51% are getting discharged from the ED, and then here 83% are getting discharged from the ED in the non-trauma centers, and obviously median is 0 days. They are getting discharged from ED. Okay, we can go to table 4. This is just the trauma centers. I just did the frequency of, if the trauma center was level 1, level 3, or level 4, and so majority of our trauma center hip injury cases we're going to level 1, 71%, and then 8% in level 3, and then 20% level 4. Let's go to table 5. Gender difference, and what we are seeing in the trauma centers, there is slightly more female, and in non-trauma centers more female, and that's basically falls are more among females, and that we see the same pattern whether it's a trauma center or a non-trauma center. We can go down. 6. And then the regional differences between the two. There is obviously central region, non-trauma center. There is not. Yeah, thank you. So there is some regional differences. I can see trauma, northern and southeastern region has more trauma compared to the non-trauma centers. The western region is mainly trauma. It's more trauma in the western region, whereas in the non-trauma centers. But that is also could be the number of hospitals available in that particular region. You can go to table 7. And that is those people who are admitted, and that's their discharge status. So 54% went home from trauma center, 82% went from a non-trauma center. So that is mainly because from the trauma center, again, the severity is high. More patients are getting discharged into long, like, SNF or a skilled nursing facility or rehabilitations. If we see that number is pretty high, 35%, whereas non-trauma centers, it's 13%. So that's the main difference between the two. That also we will see high among trauma centers, 1.9% compared to 0.4% in non-trauma centers. So these are the main differences we found between the trauma centers and non-trauma center presenting injuries. Any questions and comments on this report? Or what you want to do next? Any further steps, recommendations?
Vatsal, this is Sean.
Hey, Sean.
First of all, thank you very much for this report. I think it's helpful. If you look at the STAB report, we are very obviously underreporting the ground level fall hip fractures because they do not get sent to the trauma registry unless they're transferred to another facility. So all of the ground level fall hips that are being seen and treated in level 4 facilities with ortho were not being counted. So we underappreciated the sheer volume of these ground level fall patients.
True.
Thank you. Thank you very much. What's the difference between what we were seeing in the trauma registry versus what you got from the hospital discharge database? I think I missed that part.
So this is just the hospital discharge database, Sean. I mean, if we want to now look, and in hospital discharge database, obviously trauma centers are included, and so I just divided based on the name of the hospitals and put them into one category as trauma centers and all other hospitals as a non-trauma centers. So this has not been linked to trauma registry to figure it out, those kind of things. But we can further, if you want to look at it, do the linkage or that stuff, we can talk about that, what actually we want to get, and then, based on that, we can develop a further report.
Okay, I think maybe Vicki and I will come up with some ideas and let you know. But in the meantime, thank you very much for this data, because I think it's going to help drive some of our injury prevention efforts.
Sure, definitely. And, so I will send this report, and Sean, so this report is based on all the ICD-10 codes you guys have provided. And so we will send you this report pretty soon once I finalize it.
Fantastic. Thank you, Vatsal. I really appreciate your work on this.
Thank you very much, Vatsal.
Thank you.
I think next up is EMS and trauma data visualization of the 911 call volume dashboard.
Vatsal, it's Rach. I can help tee this one up, and if you have anything to add, we'd love to have you share some of your expertise behind how this was developed, because it's really just a remarkable dashboard that we wanted to share with everybody. What you're seeing on the screen here is the new EMS and trauma data visualization 911 call volume dashboard. The display that you see here is based on EZ-Peer's data. And although it's not truly real-time data, it's very close to real-time data. This specifically is displaying November 6th through November 9th data. And it is all of the 911 calls coming in from EZ-Peer's reports. You can see that there were over 7,500 calls last week. And below, last week call volume highlights 5 primary impressions of interest, is my understanding. Vatsal can talk a little bit about how that data in EZ-Peer's is broken down if anyone has any questions. These are categories that we thought would be interesting to track, to be able to see the weekly volume that EMS responds to across the state of Arizona. It is also remarkable, though, that there are quite a few other call types that are not reflected here.
And certainly if anyone has any questions or comments, as we do look at the data, we're happy to respond to any questions or comments you might have. This is the time period that we are working on our EMS annual report. And so any feedback that this group in particular might have could help us to shape and frame up the EMS annual report as well. There are a few other views here. This is just one page of our data visualization dashboard. And there is not just data from AZ peers on this website. We also have some fall incident data and other information that is pulled from our Arizona State Trauma Registry. So just a quick overview. It looks like Shelley's going to click through some of the tabs. EMS incidents, fall incidents, and other categories are available if anybody would like to click through and look at the other information available at the state level on our dashboard. Fossil, do you have anything else to add here? This data is both adult and peds. It's not differentiated, correct? Fantastic. I believe that we have a blog going out. The department will put out a blog next week highlighting this work, and any feedback that the TEPI committee has on this, we appreciate. Fantastic. Especially if it nearly is in real time. I mean, my goodness, last week. Yeah, big kudos to Bosco and the team. It will refresh on a weekly basis. Moving down our discussion item, discuss projects to pursue for trauma data. I didn't put a name by it. I thought the Bureau was behind this. Absolutely. Well, we added a couple discussion items here on the agenda today to see if the TEPI committee did have anything that they would like to bring forward that the Bureau might be able to collaborate with stakeholders on. Certainly, it's a busy time of year, and like we said, we are working on the EMS annual report right now. But if there are additional projects that anybody would like to bring forward, we do have, of course, Dr. Bradley and Bosco on the line, and wanted to see if there was anything that folks wanted to bring forward at this time for consideration.
You know, I'll mention the fall report that was requested for hip injuries. I think this is a really good example of kind of different data sets that ADHS collects. So ADHS has data that comes in from multiple different sources, and you can see how it's very different depending on what bucket it comes into. So the ASTR is very specific for any level trauma center, but we know many patients may have injuries and don't go to a trauma center, which is quite appropriate for them. But as we look to report data, it can really underrepresent some of our data, such as ground level falls with hip fractures. And we do know that's an area with pretty high morbidity and mortality. And so those are some examples that we can look at as we expand to the new ACS field triage guideline for injured patients into 2023. The Education Committee has put on training on that. One of the pieces that's really focusing is patients with head injury on anticoagulation. Looking at that patient population, is that something that we can capture from a hospital discharge database? That might be tricky. It's not quite as clear cut as hip fracture. That's a pretty easy injury code to capture. But those are some examples. We wanted to open up to this group and get some feedback. You can always email us offline as well if you prefer.
This is Sean. Just letting you know, you're probably not going to get a lot in regards to requests from trauma for this particular meeting, as it's happening at the exact same time as the staff conference. Yeah. So there's probably not a lot of trauma folks on.
And Sean, we have a couple of our Bureau team members at STACS today. I should be able to make it there tomorrow. As you know, folks are learning through the presentations there, and if there are ideas coming up as everyone's together and hopefully networking this week, we'd love to circle back with you and other committee members if there are ideas of projects we can pursue with trauma data over the next year. Perfect.
In the chat, we've got, Garth Gamer. Other items for consideration for the dashboard calls for opioid overdose, PEDS codes, used out, possibly pediatric feeders.
Yeah,
Take it.
sorry, I'm kind of in a noisy area. That's why I typed into the chat. But I think those would be nice to have on the dashboard if it's feasible. Thank you.
I do think the dashboard would be helpful to tease out adults and peds. It would be helpful to see, one, the volume of pediatrics, and then try to break it down from there, what the majority of those are. MVCs, drownings, what those are. Yeah. Helpful.
And, you know, the opioid overdose is something that's definitely an area of interest. The one challenge that we have is how naloxone is sometimes used in the pre-hospital setting. So oftentimes it's given without there being an actual overdose, or someone is in cardiac arrest from an opioid overdose, and so naloxone is not given. So it's always the one caveat that I have to give kind of our Office of Injury Prevention when we look at opioid data in the pre-hospital setting. It's not always that easy to pick out true opioid overdoses, because sometimes that patient population may not get naloxone, which is appropriate, but other times, other patients who have no evidence of opioid overdose are getting naloxone. So sometimes trying to capture accurate data in that regard can be a little bit challenging. But we do keep working on that. And again, that's part of what we ask this committee and EMS-RUG is working with your EMS providers in terms of how these things are documented, because that really helps us capture whether or not we think it's a true opioid overdose.
Looks like Garth has raised his hand.
Garth, did you have something else to add?
Yeah, I respect totally what Dr. Bradley had to say about that. I think that maybe the only way you could really meaningfully get to it would be a primary or secondary impression of opioid overdose, rather than every chart that where naloxone was administered falls out as an opioid overdose. Yeah, I just don't, I think it'd be valuable if it's feasible, but I don't know if it's feasible for those reasons. Thank you.
And definitely, those are the easy cases. If it's listed as a primary and secondary impression, absolutely. What we sometimes see happen is some agencies only want one impression, so they put a primary impression only. And if it's in cardiac arrest or respiratory arrest, that may be the primary impression selected. And if there isn't a secondary opioid overdose, you wouldn't capture that. So it is one of the challenges. We do have an entire opioid dashboard that has EMS data. That was, I think, on the public-facing, there's a link in the agenda. But that is one of the pieces, that there is a full opioid dashboard for the state on ADHS's website already. So we can make sure that we share that as well.
Can definitely see benefits on how pulling some of that information into the EMS website, though, specifically could be helpful. The other feedback we got from one of the regions was considerations for behavioral health calls. And that's something that I know Vasa will tell us is not easy to tease out when you're trying to create a simple, straightforward dashboard. But certainly we want to make sure that we are accurately conveying the responses of EMS in the community, which, as we all know, includes behavioral health and opioid-related calls. Similarly, I think pediatrics would be a very good one for us to explore drilling into. And Vassal, my hope would be that as we're developing the EMS annual report, we can try to develop a summary of the pediatric calls that EMS responded to in the last year. Perfect.
Yes, we'll do that.
Thank you. I'm still the magician. I think moving on to the next is a presentation, Bruce, about Safe Hearts and Arizona Registry and Education.
Yes, indeed. Can you all hear me?
Yes.
Perfect. Let me share the screen, see what I can do. Can you see that?
No.
No, of course not.
That'd be too easy.
Do you want to share? Did you get a copy, Shelley, to share?
Yes.
Bruce, Shelley can share it for you, and you can just tell her what to advance. That's easier.
That would be great.
All right.
Perfect, we can see it now.
Not on the screen, no, not yet.
Just us, though.
I was gonna say, I can't see
It
anything.
looks really good.
Yeah. We have 5 nice large screens you can see it on here.
Tech is hurting me.
Try to keep you on your toes.
There you go. I
right?
think you guys should be able to see it now.
Yes, I can see that.
Perfect.
Everybody else see it?
Fingers crossed.
Yeah. Go ahead and advance, Shelley.
All right.
So click one more. That should show another column. That's really odd. Nope, back.
Oh.
Go backwards. There we go. I am not sure why, but this shows the DHS team, DHS component of SHARE. SHARE is a public health initiative with the EMS agencies and hospitals within Arizona, DHS, and the University of Arizona's Emergency Medicine Research Center. In a EMRC, it's Dr. Spate, myself, Karen Miller is our data guru, and Robin McDonald and Christina Arns do the heavy lifting for everything that we do. All of us are very part-time on SHARE, so it's a labor of love. We work really hard to get the best data we can to you. So quick background, started in 1/1 of 05 with 62 EMS agencies across Arizona. The MICR process was implemented in 12 agencies and analyzed in 2. Just giving you some background on it. MICR showed a tripling of the adjusted odds of survival to hospital discharge and an increase of 8 times, almost 9 times for the witness to be fib. The question is, was it the procedures, the monitoring that we do through SHARE, or both that resulted in the improvement? And it probably was both. We've continued SHARE on since then and continue to monitor the system. Go ahead. So we went from 20 some odd hundred cases to 6,800 cases in 2021, which was a 7.6% increase from the year before, which was a dramatic increase from the year before that. Some of the increase is due to increased capture of cases, typically from rural or new agencies that are around the state. Some of it was a pandemic increase, and some of it was just an increase in incidence of cardiac arrest overall as we get more citizens. Currently, we have 153 agencies that participate in SHARE, 38 hospitals, of which 32 are receiving centers, cardiac receiving centers, and 6 are cardiac referral centers. We had 314 survivors in 2021, which is a little bit less than we'd seen in prior years, but the pandemic has been kind of brutal to all cardiac resuscitation. And as of today, over 7,000 Arizonans have survived OHCA since 05, which is pretty amazing and a testament to the work of EMS and saving lives across Arizona. Next slide. So what we found last year in 2021 was that Utstein survival was 32.6 overall. A very brief overview of Utstein. It's the patients most likely to survive, those that are witnessed cardiac arrest, that present with a shockable rhythm, and don't have an existing DNR. So it's a select subgroup that is able to be measured across the country and across the world. We made a dramatic improvement from 2020, sorry, and we'll talk about that in a minute. Let's go on. We're going to talk a little bit more about the Utstein survival. Next slide. Okay, so the variance. What's really interesting is the variance ranged from an Utstein survival of 54%, meaning more than half of the patients that presented in a witnessed cardiac arrest with a shockable rhythm survived down all the way to 0, which we think is an anomaly. I'll talk briefly about that. The next lowest was about 10-12%. So some of that is out of your all control. If you have an area that responds only to very old or very sick people, or a high proportion of those are patients that are not going to survive as frequently as someone who is otherwise young and healthy. However, we think that that can be moved far to the left and increase the survival with excellent care throughout the entire state, and that's what we're working for. The one agency that was at 0, we think was an anomaly, and that was due to probably missing outcomes. We're working with that agency right now, trying to track down a couple of outcomes that were missing. In cardiac arrest, analysis really is only possible with very large numbers because the survival is relatively low, and trying to measure in an agency, if you have 3 survivors over 3 years, you might have 0 1 year, 100% Utstein the next, and 50% Utstein the third. So we only count agencies with 50 a year and provide the Utstein individually for those. Our overall was 32.6, but there is a substantial variation. We'd like to bring everybody up on that to the degree that we possibly can as a state, and have everybody survive cardiac arrest when possible. Next slide. So we also measure time to first shock. This is the same, roughly 38 agencies, I believe. These are all anonymized, so just because a leader is in one graph, they might be a laggard in another, or vice versa. This is the time to first shock from time at patient based on documentation. And we came up with 3.41 minutes in 2021. And again, you can see that the range was from 2 minutes up to 6 minutes. And the statewide average is around 3.5 minutes. We do have a lot of data missing on that, 24%. We could not identify the data, that data point of what time the shock was delivered. We look through the narrative, we do everything possible to be able to identify when the shock was delivered, and if we can't identify it, then it goes into the missing data. We would like to reduce that. Some of that may be data capture through the EMS agency and into peers. Some that's just not in it. Okay, next slide. Overall ROSC rate was 17.7%. We're looking into that. We think that may be an anomaly, that we may be counting patients that are really 901Hs. We only want to count patients that resuscitation was attempted on, which means more than just a couple of compressions while waiting to find the DNR. When EMS attempts a resuscitation, whether the patient is transported or not, that counts as a cardiac arrest in our population. We do exclude traumas. We do exclude most hangings, unless it's pretty much a clear asphyxiation. We also exclude burns. So ROSC was indicated in, or ROSC occurred in 17.7% of the patients that we found. The time was actually indicated in only 54% of those patients or those cases. So based on that, we have again this time ranging from the almost 90% to about 11%. A huge missing data rate in this. Anything your agency can do to make sure that is both captured and transmitted to peers, because some agencies map differently to peers, and so we may or may not get that particular data point.
Bruce, this is Gail.
Yes.
So this might be something really that EMSRUG could kind of tackle in that group to take back to the EMS agencies, because I think this is a really, when you look at almost half of the ROS data is missing. When you look at outcomes from cardiac arrest, the longer you are resuscitating someone, you essentially have worse neurologic outcomes. And so we really want to capture patients who have ROSC and then how early they have ROSC. And so with our current data set, we're missing about half of those numbers. And so I think this may be a good opportunity to kind of take this back to EMSRUG and see if there's something we can kind of push out to the EMS community.
I think that's a great idea, Dr. Bradley. I will talk to them. Great point, because we will do everything we can to improve this. And it may not be just the agency. There is variance in how data is reported. We can only process what we get. We do the very best we can, but garbage in, garbage out, as the saying goes. So it may be more of a data collection problem than it is an actual documentation. But I'd love to get to the bottom of it. Okay, next slide. We pretty much covered this. Statewide average is not bad, but we would like to improve it. It's got a little less variability in the middle, but the ends tail off to the positive and negative pretty dramatically. Okay, next slide, shall we? This is our Utstein survival trends over the years from 18 to 21. We saw a dramatic drop in 20. We think in 18 that the reason that the data was low was because some of the agencies were coming on to peers, and we were in a transition from a manual process to an automated process. That was fully complete in 19. 20 was the pandemic, and we did see a dramatic drop-off. 21, the Utstein survival is better, although we are having some anomalies on overall survival that we're looking into and trying to identify if there's a problem or if it's accurate. Next slide. This was something that we created this year to kind of track outcomes. So you can see there's been a dramatic increase, continual increase in the number of patients called in the field. That the increase in 20 and 21 was pretty substantial. Expired in ED obviously would then go down because those patients never arrive at the ED. They're terminated on scene. Expired in the hospital has stayed stable for the last 20 and 21. And discharged alive went down last year. And again, that's an anomaly that we're looking at, trying to identify whether that's real or whether that's a variance, some sort of a noise signal that we need to work out. EMS data is always dirty, so we do our best to clean it without buffing it up into something that isn't there. So we try and do the minimum necessary to make it as clean as it can be. But we do want to verify if that's real or if there is something in the data that is odd or off. Next slide. It's counterintuitive that our Utstein went up and our overall survival went down, even though they are not measuring exactly the same things. This may be part of the problem, is missing outcomes. The hospitals are so key in allowing us to put the whole system together, because outcomes is really what determines everything else upstream. And as we have captured more rural and smaller agencies in smaller areas, many of those patients do not ever end up at a cardiac receiving center. And so the CRCs are generally very good at entering outcomes for us, which is crucial to the whole process. But a non-CRC doesn't enter data. So we only track EMS when they document a patient called an ER, then we'll document that. But they don't know whether the patient survived a discharge. Obviously, they weren't there for that entire care. So we lose survivors. The survivors tend to hide in the missing outcomes. and we're doing everything we can to get the missing outcome as close to zero as possible. For those hospitals in attendance, we appreciate all you do, and we will hound you for every last possible outcome, because that's where we find survivors. Our survival stats are terrible when we first start the finish process, and then once the hospitals get in all the outcomes, they invariably go up dramatically for survival, because that's where the survivors are at. So we appreciate everybody's efforts in getting the outcomes in. Cannot be overstated. All right, next slide. So projects we've been working on, we do individual report reviews with any agency that will call us and say, hey, could you help me understand our data? We'll look at it and figure out what we can do and try and find any errors in what they see versus what we see. We did a time to first shock audit, and what we realized was that one of the agencies called us and said, I don't think that's real. That doesn't reflect what we show. So we investigated it, and we found out that in the data, we had been looking at time from EMS arrival or at patient to the time of first shock, which is a perfect metric, unless the patient arrested on EMS. So in other words, EMS gets there, they're there for 10 minutes, the patient arrests, and they shock. That looks like a very long pre-shock period, but it actually isn't. So we excluded those. That was one of the benefits that we found from working with this agency and identifying that there was an error in the data that reduced our overall time. It was consistent prior to that because it was measured consistently, but it's more accurate now. We have worked with documenting law enforcement's involvement with CPR. They deliver almost 20% of all citizen CPR. So we have measured that and try and track that. Case inclusion, most agencies have more cases than we do because cardiac arrest is often classed as a 901H is often classed initially as a cardiac arrest. So when we review an agency, they say, hey, we've got way more cardiac arrest than you show. Almost invariably, the result is that they're counting in 901Hs. And data discrepancy, we have found errors. One agency called us and said, look, this doesn't look like our data. Our data is better than that, what we show. What we found out was they finish a call, report it to peers, send it to peers, and then they do an internal QI process, but it's not recent to peers. So we got the raw data. They were looking at the cleaned data, the data that they cleaned internally. So that's always a problem. We would like to reduce that, but it's always trouble. There's lots of variance. Yes.
It looks like there is a hand up in the chat.
Oh, okay.
Hey, Bruce, how you doing? Brandon Griffith here.
Hey, Brandon.
Hey, quick question. Last time we touched base, we were looking into a lot of the law enforcement resuscitation side of things. But when it comes to the shared database, is it only items that are reported in the peers program?
That is correct. At this point, we don't have a system to incorporate law enforcement reporting of CPR. We'd love to do that and incorporate that at some point in the future when we have a system to do that. There's such a small group of people that we're fully tasked with what we've got now. But if we get an electronic system, that'd be great. That could be important. We incorporate that.
Gotcha. We're getting a lot more involvement in law enforcement and high-performance resuscitation. Between all the agencies that we're training in high-performance resuscitation to those that are getting outfitted with AEDs and are registering them with SHARE, I would love to see a law enforcement involvement on it because they are really thriving when it comes to their resuscitation scores.
They're an integral part of the team, and we will. I'll talk with you offline and see what we can come up with because I appreciate your involvement and effort in that regard. Okay, next slide. I'll race through this really fast. These are some options. This presentation will be available We're trying to improve the data, and it is constantly kind of a whack-a-mole. You improve one thing and something else you figure out was changed, or that changed another component. So basically, some important points that we look at is CCR and MICR, when they were implemented and when they were switched to standard ACLS. Sometimes that's not clearly documented. Sometimes it is. It's kind of improved, but it's still not a consistently documented item. It depends on the agency. And then we struggle with when an airway is inserted as part of MICR, we don't know when that was actually used to ventilate. So we're trying to understand more about manual ventilation and cardiac arrest. But if the airway is inserted like many agencies do, we really appreciate knowing when manual ventilation started, when standard ACLS started, and then we can track that. Witnessed arrests, whether it's citizen or EMS. For instance, we consider witnessed if somebody says, or documents in the narrative, I heard a thump and found him down, that is counted as a witnessed arrest for us. So please note that it was witnessed even if the patient wasn't seen collapsing, but that there's a clear downtime or time of arrest. Dispatcher assisted, we want to improve that. The time the first CPR began, whether it was citizen or EMS, it's a very hard time to get for citizen. It's generally good for EMS, but it's not 100% yet. Who did the citizen compressions? Again, we're trying to figure that out and find more reliability of that data. And I already talked about law enforcement. And one thing we have seen is there is a lot of variance in times of cardiac arrest based on the monitor defibrillator. So if that can be synced regularly for a $30,000 clock, you'd think it would handle at least as well as a $5 Timex, but the monitor defibs tend to gain or lose time fairly aggressively in some cases. Next slide. We want to thank everybody for all that they do. I had listed this address inappropriately or incorrectly. The address for share on DHS's website is azshare.gov. And my email address is bjb1@arizona.edu. I'm very easy to find. And we really appreciate all that the hospitals, the EMS agencies, the fire departments do to improve outcomes. And we're really excited to continue and grow this program. Seeing some questions pop up, but they disappeared on me. Can you read those off, Shelley?
Sure. Garth's asking if there's any reports dealing with compression devices versus manual compression, and then obtaining of raw.
So on the manual devices versus automatic devices, or manual compressions versus automatic, we do collect that. In fact, we've done a fairly extensive process. I can tell there's a lot of dinosaurs on Phoenix Fire like me because we find an inordinate number of automated devices being called the thumper, and we've mapped that to mean Lucas. So we do collect that. We see that in other areas. We try and track automated devices, but when the device was applied is a difficult thing to identify. We haven't seen reliable enough data that we can routinely collect when the mechanical device was applied, but we do document that. Yes, I agree, Garth. I've been at this way long time. Can still hear thumpers in my sleep on occasion. And then the other question, the other part of that question from Dr. Gamer?
Any reports dealing with obtaining raw?
If you could ask that specifically, Dr. Gamer, that would be helpful. I'm not sure what you're looking for.
Sorry, Bruce.
No worries.
I've been typing in the chat because it's noisy here. But anyway, the success rate with device assisted, like the Auto Pulse or the Lucas device?
We have not set that up. We don't have the data to be able to measure that accurately and know when it was switched and increase or measure an increase or decrease in survival. What we do know is that mechanical devices don't seem to be inferior when they are not applied or when they are applied quickly. The bigger problem we find is that mechanical CPR application can take a lot longer than it looks or feels like, just like intubation. Always happens in 10 seconds until you watch it on the clock. So we encourage agencies to practice and document their time of application and make sure they can apply it in less than 10-second intervals. But as far as data that's reliable, we don't have any on the success or problems with either approach over the other.
Thank you, Bruce. We had asked Bruce to do a presentation on SHARE. We recognized there's been a little bit of time since that presentation had been done for these standing committees. So we really do appreciate that. We have a couple other items in the agenda we want to try to cover as well. So thank you again, Bruce, and for those who asked questions. Really important data and have made Arizona one of the leaders in resuscitation nationally. I'll turn it over to Chief Garcia.
Well, for the next agenda item, again, thank you, Bruce, and everyone that's involved in SHARE. That was a great presentation. But
of
for the
course.
next agenda item, trauma registry needs and providers, we really just wanted to create an opportunity if the TEPI committee did have any considerations that they would like to bring forward as we begin to research trauma registry options and the two vendors that are in this space currently. We'd like to make sure that TEPI is able to bring forward those considerations for the department. We look forward to working with our user groups and our committees as we navigate that process. As you all know, we really are left with no choice here since Trauma One is being phased out. Our hope is that we will have the year of 2023 to really research and determine which product we will go with for the new trauma registry. And likely we'd be looking at 2024 for implementation. But that's a very rough estimate. We don't know for sure our timeline yet since Trauma One will not be phased out quite yet. So I will pause there and just ask the group if you have any comments at this time. And if you don't, certainly you're able to follow up with me or anyone at the Bureau. I think most of you have Carissa's contact information as well.
I think just one question to ask both of the vendors is, we noticed just from going to our Trauma One to the state web, it created duplicates. So it gave a new patient ID. So now when we get our ACS CEQA benchmark report, some patients are there twice. Not the new one. So now, like our acute kidney injury, we had 19 patients, but only 13 were real patients, and 6 were duplicates. Because all the resubmissions that we do is creating a new patient ID. So I guess we have to ask the vendors if the same patient ID can go over to the new system. Because it's gonna, for us, it's gonna hurt us for 2 years until all the old data goes away.
Maria, I think that's a good point. I know I've spoken to both of the vendors that we're looking at, and they both will have to move over our data regardless of who we go to. If we go to ESO's new system, they're going to have to transfer over our old data, and same thing with Image Trend. And so that's definitely a priority to have our data transferred over and in a correct way where it's usable and like you said, not causing errors. So if you want to email me about that, we can see kind of what's going on, see if ESO can do anything about those duplicates as well.
Yeah, I did ask Alex last week, and he said we have to speak to a salesperson for ESO. He did not give me an answer.
All right. Yeah.
Offline. And,
Yeah.
Thank
Okay.
you. The next item, I think we will need to table because we probably need more than a couple minutes to discuss this. We wanted to look at the ASTR public data set and kind of how we break up the age groups, really looking specifically at pediatrics and some of the geriatric groups. So I want to make sure we have ample time to discuss that. So if the group's okay, we'll table this until the next meeting.
And then any agenda items to be considered for the next meeting, please send that to Shelley. And then call to the public. If there's any items that the public would like discussed. Upcoming events? Upcoming events, as we've said several times, STACS is currently going on this week. In December, there's AIMS, third annual EMS, which is virtual. In March, there's also a pediatric symposium in Flagstaff, and in June, Southwest Regional Trauma Conference. And then in July will be WPTC in Carlsbad.
On the line. Yeah, Shelley is displaying a save the date also for an additional event that we'll need to add for upcoming events. And Marissa, are you on the line to share any information about this upcoming seminar for base hospitals and medical directors?
I am on the line. Do you guys have a minute just for me to, just a quick plug? Okay, so as you can see the invite there, it's for, I know these have been missing for a while. They went away during COVID. We want to bring them back, maybe in a little bit of different structure where the focus really is on EMS-based hospital and medical direction. So we really want to invite all EMS medical directors, base hospital, pre-hospital managers, coordinators, really anyone wanting to learn more about the ALS-based hospital programs and pre-hospital structure throughout our state. This seminar, we're working together with Chandler Regional and Mercy Gilbert Medical Centers and the Chandler Fire Department, and I'm super grateful for their involvement there. As this invite shows, it's scheduled for January 10th, 2023 from 9:30 to 1. So it won't be a large time commitment, only about 3.5 hours, but we really promise to make every minute count. We want this to be the best possible event. And so we really need your participation. It will be in person with a virtual option. So please come in person or online. We are meeting at the Chandler Fire Training Center. Let's see what else. An invitation did go out at to the base hospital listserv. For those of you who did receive the invite, if you want to pass the information along to anyone, please do so. For anyone who may have missed, or if you want me to email an invitation to someone, please let me know. Also, if there's someone that you want added to the base hospital listserv, also please let me know. I think that's about it. Do you have any questions? We're really looking forward to this event. We really think it's gonna be a great opportunity for networking and just, I don't know, enlightenment. I'm really looking forward to learning a lot from all of you.
Perfect, thank you. You can visit the Bureau's news and conference page for more upcoming events, also for CE opportunities. Our next meeting is March 16th of next year. And I think we're adjourned.
Great job, Carrie.
Thank you for suffering through it with me today.
Thank you, everybody. Bye.